I'm going to introduce our panel, and they will begin talking one after the other. Okay, let me give you a brief bio on each of our panelists. Sandra Oaks is a geriatrician and palliative care physician. She currently works in co-leading the Bridges and Palliative Care program at San Antonio WellMed Medical Management. Dr. Oaks' roles include expansion of palliative care at WellMed, as well as to collaborate with Optum leadership in the implementation of innovative palliative care models nationally in the ambulatory setting. And for those of you who are not familiar with palliative care, you'll learn about it in just a minute. She has extensive experience working in geriatric and palliative care services in the continuum of care from hospital to clinic to long-term care and now house calls, which WellMed is doing. She was the recipient of the American Medical Directors Association National Award as the Best Medical Director of the Year in 2014. Up next, our friend Carol Birch, an attorney elder law specialist, and we've had her on Caregiver SOS on air a couple of times. She did a great job on the radio show, and I'm sure she'll do a great job here. She is an elder law attorney serving San Antonio and the surrounding communities, received her Doctor of Jurisprudence degree from the University of Texas School of Law in 1992. Since opening her practice in 96, Carol has been a champion of the elderly and disabled. She even makes house calls. You could hook up with Sandra here. She makes house calls to those unable to get out so they can receive the full benefit of legal counsel. First and always, she treats clients with the dignity and respect they deserve, appreciates the wonderful tapestry woven by their life experiences, and with patience and understanding, she helps her clients plan for the challenges of aging. Picking up from John's talk this morning, just be happy. You can clap. Cool. Next up is Diana Taran. Taran. She earned her undergraduate and graduate degrees in social work from Our Lady of the Lake University here in San Antonio, and she also was born and raised here. Turn the page. Okay, next year we'll have each on one page. She's worked in the field of aging for over 18 years, beginning as a facility social worker in long-term care. Been with the Alamo Area Council of Governments, Area Agencies on Aging for the past 16 years, and in January 2018 was promoted to the position of Caregiver Services Coordinator, overseeing the agency's National Family Caregiver Support and Health and Wellness programs. She's a certified benefits counselor, and you will hear from her in just a moment. She's also a member of the National Association of Social Workers. And then finally, up next, Tina Smith. Tina Smith is the manager of the Caregiver SOS program through WellMed's Charitable Foundation. She has a bachelor's degree in psychology, a master's degree in social gerontology. Tina started her career working in the long-term care industry as an activity director and social service director. She then moved on to serving as the local managing ombudsman at the Area Agency on Aging, where she was an advocate for residents in long-term care facilities. After serving in this role for 2.5 years, she then became the Access and Assistance Coordinator at the Bay Area Agency on Aging, where she supervised the in-house programs of benefits counseling, care coordination, and information and assistance. Tina's taught gerontology courses at Kaplan University through their online human services program for over 7 years. She's been with the Caregiver SOS program since September 2016. Yay, Tina! Okay, we'll start with Dr. Oaks.
Okay.
Let me move out of your way here.
Thank you. Thank you for having me today. I'm going to stand up. If you know me, I get very nervous if I sit, so I do better if I stand up. I just wanted to say thank you for inviting me to share with you a few thoughts and ideas to keep your curiosity high and regard issues with end of life and understanding what we can support you through palliative care services. Raise your hand if you know what palliative care is. Okay, there are few hands. So for the one that you don't know, I'm going to try to review this, which usually takes 30 minutes, an hour, in 5 minutes, and then tell you a story that can kind of portray what we can help the families that are facing serious illness. Palliative care is a specialty that is very different from many because it's interprofessional in nature, meaning we have multiple disciplines caring for people that are seriously ill. Many patients and families have the misconception that we are hospice. So hospice is a terrific interprofessional service that is paid by Medicare when you have less than 6 months of expectancy of life. We, palliative care, come before that, 2 or 3 years before that end of life issue. And a big difference is we can come along in a patient that is having a serious illness, but they are interested in continuing getting aggressive care. So I'm going to tell you a story. I have a patient, Alicia, who has been married 30 years with a native Mexican. So there is a lot of bicultural things in this family. She came from a marriage with 8 children. Unfortunately, 3 years ago, she developed cancer. The cancer was in her belly, and the cancer is spread in several parts of her body. At that point, 3 years ago, the news were devastating. Imagine you are in your 70s, you are trying to enjoy your grandkids, and then you receive this news that this cancer is now part of your life. They have very low literacy, a lot of challenges understanding medical care, what to do, what questions to ask. Start asking the questions about how I wanted to spend my life, and they were lost. So the initial visit was, you need to go and get all the treatment possible. There were a lot of issues with communication with the healthcare system. She received the treatments, didn't understand completely her prognosis, how the treatments were going to be so hard on her, and that's when we got a call by the primary care and said, this family is lost. They wanted to continue doing as much as they can, but the time is limited. Can you help us? So what we do is the patient is seen in our clinic, or if they are already homebound, we can do a visit at home. And the visit starts asking very important questions. How much do you know about your illness? Do you like to know everything about your illness? Or you are like many Hispanics and minority groups where they don't want to know everything, but they want their daughter or their spouse or another person to know those news because they don't want to know everything. We ask questions such as, have you discussed with your doctors what treatments are you getting and what that means to you? Do you understand the risk benefits? Have you ever thought about don't doing a treatment? For many patients, they said, the doctors never have told me that I could say no. And when for the first time you can say, you can take power over your illness in your trajectory and say, maybe I wanted to consider something else, that brings power to a family and a patient. Then we can talk to them about their prognosis. You know, we read the history, talk to the oncologist in this case. So we can say things such as, we have days to weeks or weeks to months, so we need to think about what is important to you and your family. What are you hoping for with this treatment? What are your fears? How much are you going and be willing to go through in order to gain more time? Where do you get your strength, your spirituality? Do you believe in God? Do you have a faith community? Do you have friends visiting you? And then after all of that conversation, which is not about your cancer and the chemo, then we can understand how we align our care in that story. And in the case of Alicia, Alicia wanted to live as long as she could because a grandchild was going to be born in the next 6 months. For her, this relationship with David, her spouse for 30 years, was vital. She goes to a non-denominational church and she has been emotionally and spiritually isolated because she couldn't go to church anymore. She was already struggling with fatigue, depression, couldn't eat, have multiple pain that wasn't treated at that point because the healthcare was focused into chemo, chemo, chemo. Nothing wrong with chemo. But when you don't see the entire picture from the patient, the symptoms, the family, their community, we are moving in the wrong direction. So today, the two teaching pearls for the whatever minutes I have is that we were able to deploy my social worker, get one of the hospices where we borrow a pro bono chaplain to address the connection between the spiritual pain she was suffering, getting the church to mobilize resources and bring communion to the house because she couldn't go to church anymore. Our social worker was critical and starting preparing the family for questions such as, what are we going to do when she cannot speak or make decisions? And Carol will walk us through the journey of the advanced care planning. And if she is so sick, is she okay having a natural death process, or she wants to have more aggressive care and dying in the hospital? Which, by the way, she says, no, I love my bed, I love my home, I love my kids. I don't want to be in the hospital. I don't want it to get those tubes. So we could execute documents that were very important, and David and her daughter, Rosemary, were able to hear, to communicate to the other 7 siblings. We initiated medically a lot of treatments to ease their pain, physically speaking, and start easing the pain emotionally, psychosocial that this disease has. She stayed with us. We stabilized her symptoms. She started eating better. The pain got controlled. The social worker got her more services and a provider. And then she declined to the point she couldn't walk anymore. At that point, we partnered with one of our hospices. She enrolled hospice, and she was able to live for a couple of more months, and she died at home. Surrounded by her family, the pastor was able to come, a lot of closure. They were able to prepare financially. Nobody really thought that they needed to talk about how you get buried in this country, how much it costs to be cremated versus things that sometimes we kind of put in the back, burner. We don't want it to deal with that. So our program is here to serve you. Well met. I lead the largest program of palliative care right now in the country. We have 450 seriously ill homebound patients at home. And we are leading palliative care in the nation in regard models of care, identifying the right patients with congestive heart failure, COPD, end-stage renal disease, and other diseases. So if you have further questions, I will be available for a few minutes after. But think about that. If you're going through a journey, you don't need to be by yourself. We need a village to help you, and we are part of that journey. Thank you.
Okay, wow. What a story. So for the patient that Dr. Oaks had that she mentioned as she was going through this journey of serious illness, one thing that all of us need, that patient needed, was to talk about what her values were and what was important to her. And in addition to talking about it, what we want to do is put it in writing. Putting it in writing is a good way of initiating those conversations, saying, look, I'm having to do this, I'm putting this in writing, so let's talk about it. So what are we going to put in writing? We're going to put in writing a medical power of attorney. That's just a piece of paper that lets you say who is going to make decisions and who's going to handle dealing with medical providers if you become incapacitated, okay? So as long as you have capacity, just like Dr. Oaks' patient, as long as she had capacity, she made her own decisions along with her family. And you make your own decisions while you know what's going on. But if you get so sick that you need, that you're not able to function and not able to know and understand what's going on with your illness and what the options are for you, then you need someone to be in charge, and that's your medical agent, the person who's in charge under your medical power of attorney. To help your medical agent, there's another document that we do called a Directive to Physicians. Now, this document is very cut and dried. It says, if I'm in a terminal condition or if I'm in an irreversible condition, and I'm incapacitated. Remember, it only applies if you're incapacitated. So as long as you have capacity, you are in charge and you make decisions. But if you lack capacity, it lets you say, if you want life-sustaining treatment under these conditions, or if you don't want life-sustaining treatment under these conditions of being either terminal or in an irreversible condition. So those are the two pieces of paper. Those are what we want to put in writing, is the medical power of attorney and the directive to physicians. And that's what we want our loved ones to have in writing when the time, to prepare for the time that they may be incapacitated. Okay? So there's going to be some questions afterwards, and I'm happy to answer those as well. But that's our basics: powers of attorney for medical and directive to physicians.
Good afternoon. I always prepare things and I'm like, and then I hear everybody and then I'm like, wait a minute, it's maybe thinking of other things. So I just want to share, when I was first asked to be on a panel of experts, I hear experts, and I'm like, and my first being a human instinct, I'm like, I don't have all the answers, and oh my God, they're going to ask me questions and I have no idea how to answer that. But when I hear the word expert, I feel I'm an expert. It's not because I know everything. It's because I know all these other people that I can refer our family caregivers to that have the answers, and hopefully we'll be able to help them, and we're all in this together, right? And so when that also makes me think of when I work with our family caregivers, the idea of how come I don't know everything, right? I should know everything. So what I expect from myself is what I would expect for family caregivers. You aren't going to know everything. You're not going to have all the answers, but we want you to be able to get to those people that have the answers, right? So through the Area Agency on Aging, our National Family Caregiver Support Program, we are tasked, we receive federal funding through the Older Americans Act to serve family caregivers of those that are 60 years of age or older, or if they have a diagnosis of Alzheimer's dementia, they can be under the age of 60. And so we have kind of 5 critical areas. Basically, respite is our biggest provider services. So that could be in-home respite, that could be with adult daycare. And then we also have what I do when I go out and I present. It's giving caregivers that information. What is out there? What's available to me? And how to access those services. And we definitely have I could spend the whole day talking about the services that we provide through the Area Agencies on Aging. But definitely, again, really the idea is we want to be that contact for you, that if you don't know where to go, what questions to ask, then we will hopefully be here to be able to guide you in that. A lot of our staff is here. I'm pointing to the back table, so after, if you haven't visited the table, please, definitely we're here for you in terms of the services, what we do directly, what our funding provides, and that we also do education and training. We are part of the Stress Busting Partners. We also do other evidence-based training, but again, really being there to support family caregivers. Oh.
Okay, you all have been given a great deal of information today, and I mean, I'm sure it's probably overwhelming trying to keep up with who said what and what you need to do, but I just want to say you've taken a great step, because one of the things with the Caregiver SOS program, we have caregiver specialists available that can talk to you and provide that information and provide guidance, because it is overwhelming. Like I said, you've received a lot of information. There's a lot of different agencies out there, and it's hard to know where to start, especially if you're in a crisis or you're long-term caregiving and it's just, you're making it day by day. Where do you begin? Where do you start? And so one of the first things that I think is important is to educate yourself, which you all are doing today, which is very important, is to learn. Don't be afraid to ask questions. As everyone up here has said, you've got to ask those questions, open those lines of communication. What is it that you want? What does the person you're caring for want? And have those. Those are tough. Those are tough conversations sometimes, but you need to have them, because when the communication lines are open, everyone knows what's going on. Everyone has a good understanding of what to expect. Jobs can be assigned for different people. Boundaries can be established, because that's important. And I realize in a lot of caregiving situations, you may be the only one. You may be the primary person providing that care, and you can't get everybody on board. All you can do is do what you can do. You work with your family, keep those lines of communication open, but do what you need to do as that caregiver. It's important to be educated, to learn, and you don't have to know everything, but know where to go. Know that you can come to many of these different agencies here and say, I'm just getting started, I don't know what to do, I don't know where to turn, and we can help you with get started with that. But asking those questions, having those conversations are so very important. Also, as a caregiver, it's very important, and you may have heard this before, I'm sure, but you need to take care of yourself first. You really do. It's not a luxury. It is not selfish. It's a priority. It really is a priority. I'm sure I will go ahead and give the analogy. It's a very common analogy that you hear, so excuse me if you've heard it before, but the airplane analogy. When you're on an airplane, and the stewardess is going over the rules, and they say if we hit turbulence, the air masks will drop down. What is the first thing you're supposed to do when those air masks drop down? You put it on yourself. Even if you see they say, even if you see someone struggling next to you, someone that needs help, because if you don't put it on yourself first, you're going to pass out, right? You're going to pass out. Well, caregiving is very much like that. You're giving and giving and giving, and you're making sure your doctor appointments are being taken care of. You're making sure legal documents and are getting done and all of that. But so oftentimes we find many caregivers that just aren't looking after themselves. You're just not taking the time that you need. You're not making it to the doctor appointments. You're not getting the sleep that you need, eating the meals that you need to. And so I can't stress how important it is that you do take time for yourself. I love that you're here today because that means you're taking some time to learn. Maybe you're getting a break today, socializing with other people because, again, sometimes it can be pretty isolating. You find yourself kind of moving inward, and because you're so busy taking care of the person your loved one. Again, it's important to connect with other people. We all need to connect at some level with other people. So taking care of yourself, like I said, I'll repeat it. It is not a luxury. It is not it's not being selfish. It is a priority. It's something that you really need to do. And so again, thank you all for being here to learn to take a break, meet some other caregivers that are very possibly going through some of the same things that you are. But reach out. There's help here. And I know, like I said, you've been given a lot of information. Don't go home and put it on your counter and say, I'm going to get to it later. Take that step. Be intentional to do at least one thing for yourself.
Thank you, Tina. Thank you. Cards on your tables if you want to write out a question. I have a couple I'm going to share with the panel. But before I do that, I want to bring you an opportunity from UT Health. Their clinical research on aging is looking for volunteers, and in exchange, you'll participate in clinical research studies investigating conditions common to the aging population, and you can end up with free, great health care. You may be eligible for one of the current studies: healthy aging, obesity, diabetes, loss of muscle and strength, frailty, geriatric conditions, metabolism, and healthy weight. Someone said, I got all those. Well, you're perfect then. They'll sign you up today. Hey, that's great. In fact, they'll come pick you up. That's perfect. What can someone do when they need to have someone to care for them, but they have no family to act on their behalf? Actually, that's everybody on the panel. So in other words, they need help. They've got no family. What do? They call Tina or Diane. Diane,
They call
why don't you say?
Diane.
And then I say, call Carol.
Yeah. Why don't you explain? There's your microphone. So, and you got to turn it back on. Oh, cool.
We do get a lot of those. No, it's not.
I saw you turn it off.
Did I? Oh, there it is. Okay. So we do get a lot of those calls in terms of because we say, I think some people feel like when they get support, it has to be from family, or if a caregiver says, I'm an only child, and there's right? There's nobody else. So a lot of times we say, what are those other connections? And sometimes they have to be professionals. So is that reaching out to find an elder law attorney? I know we have life care managers here in the back. Hey, Byron. So really kind of reaching out to find if that does mean someone legally has to take control of their needs, all of that. But yes, I mean, that's something that we can get that call, but finding those experts that will do that. And I'm going to let Carol, you might be able to answer a little bit more on that legal side.
The good thing is always to have money. If you got money, people will help you. So the person who asked the question did not say that they didn't have any money, so I'm going to answer as if they do. We can always turn to a corporate trustee to help take care of finances and manage if you become incapacitated. So that's if you have assets other than your house of at least $300,000, really, is where a corporate trustee is going to come into play. If you don't have that, and you really don't have the family members, then there are some other professionals, as Diane mentioned, aging life care specialists are great to maybe step in, and if they can't serve in the positions that you need them to serve in as your agent under a financial power of attorney or your medical agent, they can at least help you brainstorm about who is out there, family-wise, friend-wise, church relationships-wise, to help you. And Dr. Oaks, what do you tell people?
So we see all sort of scenarios and pretty much reinforcing the same. I think we need to start rethinking in America who can help who, because we're going to see more and more people that are going to be loners. So we need to be good neighbors. And we have several seniors. I was talking to Debbie. You guys are going to have a federal grant looking into people with dementia living by themselves. They already outlive every single family member. And now we're looking into their community of believers, the pastor, the next door neighbor, the lady that cleans the house that is going to be helping. But the important thing is don't wait until they are demented. We can really be proactive to hear their voices. I also have dealt with priests and nuns where they don't have any other relative, and trying to explore more the goals of care and who can represent them. And there are cases where if we wait too long, when we enter in their home, they're living already without electricity, dead cats in the home, they haven't eaten. Those cases are brutal to witness as the healthcare team goes, and those require adult protective services. We use a lot of Catholic charities, initiation of guardianships, where sometimes nobody wants to care for them. You exhausted the church. There is no family. There are no resources. APS have done a tremendous job. It's a little bit slow, but attorneys like you that serve on behalf of people that cannot make those decisions. And remember, the goal is, who likes to die in the nursing home? Raise your hand. I never have seen anybody that says me. So the idea is, can we put processes in place so people die, hopefully, in their preferred place? But sometimes we need nursing homes or personal care homes that are safe. So again, we really advocate to be proactive and don't get to the end. Hopefully that.
Thank you. Next question. Is there a minimum time a senior citizen needs to live in Bexar County before being eligible for Medicaid?
No.
Well, there you are. We'll move on.
Well, just so you say, as long as you intend to be a Texas resident, you are a Texas resident for Medicaid purposes.
Okay. Next question. How do you get started on dealing with all these issues for a family member who's not 65 years of age yet? So maybe it's dementia, maybe it's a chronic disease, maybe it's whatever, and they know they're going to need help. Can you get the ball rolling? Don't all answer at once.
No. Sure. Definitely. And that's why, again, I say we as professionals, why we develop partnerships and people in the community. I know with my agency, I have certain limitations. I'm entrusted with federal funding, and we have certain, requirements. So I know my 60 plus or those with dementia, Alzheimer's can be younger. We have a wonderful coalition, a caregiver coalition. WellMed, the back table there is wonderful experts. A lot of the people that you've gone to their tables here before, because I know that if I am not able to serve that community, I probably know somebody or who can get to that person. So again, why we know that we, in the areas that we serve, that we can also find those other professionals or agencies that can help with that. But again, we try to be the no wrong door in terms of our services. That again, call. If we're not exactly that person, we never want to turn somebody away, say, no, that's it, sorry, here you go. We want to build those connections. We want to build our resources as well so that we can then try to find somebody. If it's not us, then our partners can possibly help with their services.
And just to piggyback on what Diane said, it is important. Sometimes you just need to make that first phone call. And I'll admit, sometimes our services are hard to navigate. It can be very overwhelming. There's a lot of different agencies out there that do a lot of different things and do have different requirements. But it is important to at least start those questions, call somebody, and you have to be sometimes persistent. Be very persistent in when you're calling, and not always take no for an answer. Sometimes you need to be that advocate for the person you're caring for, or even for that neighbor. Or a coworker. You need to help them along. It's okay to speak up and ask those questions and to say what you need to say to get the answers that you need.
Next. This is a good question. I think Carol. Can you talk about the legal transition when a loved one dies, power of attorney to duties of executor, etc.?
Okay. Remember that your power of attorney expires when you expire. Okay? So when you die, when your loved one dies, that power of attorney no longer has effect. The powers of an executor are not in place until the court has admitted that will to probate. So there's a period where you're kind of in limbo and you don't have authority to act for the person who has died. In that case, just real quick, you might want to have the care recipient might want to have set up an account that the caregiver can be on as a joint owner so that they can pay bills or make sure that costs get taken care of. But there is a short period of limbo where the power of attorney is no longer effective, the executor is not in charge yet, and we don't have anyone in place. Now, if we have an emergency, we can always set up an emergency administration and get that executor appointed.
Dr. Oaks. And it died. Hello. Happy Halloween. Dr. Oaks, you explained palliative care, but your bio also states you are a geriatrician. What in the world is a geriatrician, and what is geriatric care? At what age does someone seek geriatric care, and what specifically may trigger that need?
So a geriatrician is a physician that has extra training in older adults. And if you are from the Health Center of Aging here, there is a big discussion when that time starts. So you can have different answers, but we pretty much are looking into 60 plus, 60 plus, 65 plus as the age of retirement. In this community, we have people at age 55 that have so many brokenness in their bodies that they are behaving like somebody in their 80s. So a geriatrician usually look into 60 plus, 65 plus, but we have seen also people younger in their 50s, early dementia onset. So we specialize in geriatric syndromes, dementia care, incontinence, fall risk, polypharmacy, frailty, sarcopenia, unintended weight loss for multiple chronic illness. So I have seen usually, when I was in UT, we have a cutoff of 60. Here in WellMed, we have my youngest patient, because I'm a geriatrician palliative care, is a 43-year-old with stomach cancer. And a patient of mine died with, 7 heart attacks, renal failure at age 39. So again, in this community with Hispanics, African Americans, the burden of illness is huge. Their bodies are behaving bad, so a lot of my expertise apply to those. But again, in our practice, we're a geriatric group in WellMed, but we have all sort of ages due to other insurances, but we focus in those complex geriatric syndromes.
Thank you. Next question. My father-in-law has a Georgia DNR. He lives in Texas now. Does he need one from Texas? And does it need to be notarized?
Yes and yes. Do you want more? No?
Now, I will say something just, if you have, and the DNR in the state of Texas has two ways to be validated. One, if you have 2 witnesses, or if you, and so I say that because some of our patients cannot leave the home, or they cannot go to be notarized. So you can also find the 2 witnesses not related by blood or marriage and all of that story, so that Carol can recite better than me. But I will say, yeah, if you wanted a notary involved, you need to do it. But if they're homebound or they come to the WellMed clinic, we follow our guidelines and we can notarize that. Now, the DNR must be signed by a physician. It's a physician's order, versus the medical power of attorney where the physician is not involved. So just remember that the DNR requires a physician's signature.
Renee, can you get the IT guy? Our batteries died on one of these mics. Thank you. Don't call me at work. Here's another question. Once the will goes to probate, and everything is done, do you have to go back to court to close the case? And if you didn't, what will happen?
That's a great question. Here in Texas, we usually do not close probates, so you don't go back to court. And so if you didn't do that, don't worry, nothing will happen. Nothing bad.
That's a great answer. Is palliative care different from health care? How does one get to palliative care? Do you need a referral from your primary care doctor? Dr. Oaks.
So healthcare refers to the largest spectrum of services that a patient, and their family can incur to, right? If they get sick, they go to specialty care, they have a primary care doctor. Like in WellMed, they also can have access to health coaches, social workers. If you are suffering a serious illness, such as you are in your 2 or 3 years before you die for congestive heart failure, end-stage renal disease, end-stage dementia, any type of cancer, plus other criteria, if you belong to a system that provides palliative care, you can always ask your primary care, I would like to get supportive care services by palliative care. The referral goes in WellMed to us, and we look into the criteria. And the patient can be seen in the clinic with palliative care services, or if the patient is homebound, we will enroll them, insert them in their house. The problem is, not everybody has palliative care. The major programs in palliative care are in hospitals, and that's where the majority of you maybe have heard the word. And that's the reason in the past 10 years, the move has been to how do we sustain programs that not only see the patient that got the newly diagnosed or really bad heart failure for a massive heart attack and they survive, and then they get the good palliative care doctor and social worker in the hospital, but then they get discharged home and there is no more help. No more services. So what we did in WellMed very proactively is deploy the same continuum of care, not only in the hospital, but we follow the patient in the clinic or in the home until we pass them to the next level of care, which is usually hospice. So again, there are models of care like Gonzaga has currently. They just opened a program similar to us. And there is Opus and some other healthcare like a Spiral Healthcare that is trying to figure out how to do palliative care in San Antonio. But definitely the strongest and longest and oldest program in Texas is through WellMed. there are systems that do not. UHS, if you are from UHS here, UHS has also a great palliative care program, but they only do clinic. They don't follow patients in the home. So again, we are still trying to develop more help where it's needed in a model of care where payment systems are not paying for those services. In WellMed, we are blessed to have a lot of support because we're already proving a lot of benefits for the caregiver and the patient.
Thank you. How do you go about getting paid to be a caregiver for a family member? The answer is?
That's a tricky one. Usually I refer to, so Medicaid, the long term, is typically certain circumstances. There may be in their funding. But that with Medicaid, you do have to be income and resource qualified. Now for our services through the area agencies on aging, the goal is to give the family caregiver the time away from the responsibilities of the respite, so we're not able to pay an actual identified family caregiver for services rendered. But yeah, usually I typically refer to the state services if they're qualified. Now I must say that we do have a voucher program if everybody's interested, where you can actually, if you've identified, so it's more of choice, provider of choice. Typically we work through home health agencies because we provide short-term. We don't do long-term through the area agencies on aging. It's typically a short-term service. And we have contracted through home health agencies. But we do have a voucher program, so if you have a family member or friend that is more trusted, just especially a lot of in our memory care, we know that change can kind of disrupt a lot. So if your loved one is familiar with someone already, as long as they don't live in the home as your loved one, that person may be able to get directly paid for respite care for them. It's still a short term, but that is something that is offered in some of our caregivers. If they can't be the paid caregiver, then it may just be helpful because I think it's that familiarity with being the caregiver. And also, I must say in terms of Texas, it's difficult because there are other states that do pay because it is a full-time job for a lot of caregivers who have to quit their own job to care full-time for their loved one, but that is something hopefully we'll be working on, but that's legislative and Texas does not allow for that. So.
Okay. Asking for a friend. You are executor to your husband's will. How do you handle adult children from a former marriage who fight you on how you manage the estate?
Give you your car.
Yeah, it's a very complicated question.
Yeah. Call
And the answer
a
is,
litigator.
go ahead.
Call a litigator.
You need a lawyer.
Yeah.
If you have one who's handling the will and the estate, perhaps they're prepared to do that, but it's very complicated. I'd say hire a hitman, but that doesn't always work. Or a woman. A lot of legal questions, which is okay. Carol, you got a thriving practice. Oh, this is a good one. Dr. Oaks. Oh, hi. When?
No, I was ready for her.
Yeah. When should the physician sign the DNR order? At the time it's initiated or at the time of terminal illness?
So these are really interesting questions because if you ask an 18-year-old, have you ever thought about dying? They don't get it, right? So we usually wait until the patient is suffering a serious illness because we know they're going to be near to death and we need to talk about the future. So that's a very important thing. Even though we encourage anybody 18 and older to have a medical power of attorney, when you are facing death or a serious illness, that's when the out-of-hospital DNR is relevant. Now I wanted to clarify, if you get hospitalized, the physician can write a natural, do not resuscitate order, but if you leave the hospital, in Texas, you better sign a different document that is a piece of paper that says out-of-hospital DNR. And that, again, is a dialogue, it's a conversation, not about like, hey, if something bad happened to you, would you like that we do anything? Because your answer will be, of course you do something if I'm dying. Versus asking the question of, in the context of your serious illness, things are looking pretty bad. You know, you have been admitted already twice, and we have data. If you have been hospitalized, you're an elderly patient, you have had 2 unintended hospitalizations in the past year, your chances of dying are 50%. That's pretty big. So in that context is when we had the dialogue of this document, and it's in that moment that we want it. What will be the problem if we do that too late? The patient is going to receive the care they don't want. So the important thing, and I love the question, is this is a very important conversation, not when you are in an emergency stretcher getting into the ER. It's hopefully when everybody is calm, and yeah, it's emotional. We actually encourage these conversations when you are in Thanksgiving because that's the only time that you maybe are going to have the conversation with your mom, your dad, your uncle. So you don't get the call in the ER or calling the attorney or what we do here. And we want this when the person has a voice. Do it when the serious illness is diagnosed, when we know there is a terminal illness, and we wanted to know that you want a natural death process. Two clarifications. DNR doesn't mean do not treat. Big difference. So if you have an out-of-hospital DNR and you go to the hospital and you have pneumonia and you find an incompetent healthcare professional saying, oh, you have a DNR, I'm not going to treat your pneumonia, you can turn down the document. These documents, you don't marry with them, you can change your mind. So we fight that a lot because people sometimes, especially minority groups, Hispanics, African Americans, have been neglected in healthcare. They don't want to sign that document because somebody in their family maybe didn't get care because of that. So we're trying to change that. And we empower the families and caregivers that the document only guides 4 things. They cannot do CPR, they cannot put you on a ventilator, they cannot put you a transcutaneous pacer, and you are not going to have a defibrillator placed. That's the 4 things that you do when you sign an out-of-hospital DNR. It doesn't say that you cannot receive pneumonia treatments or a surgery for a broken hip or a UTI management. So I appreciate the extras on the question because there is a lot of misinformation about these important documents that are just intended to know that there is going to be a peaceful transition when you die.
There's a sidebar to that question, and that is, does EMS honor a DNR when they come to your home?
Absolutely. It should be placed in the refrigerator. And it's funny, I didn't know this, and I do palliative care. The idea is that the document will be in the freezer just in case the house get into fire. The document won't burn. The reality is nobody placed them in the freezer, but we tell them to put it in a universal place, which is your refrigerator, the hielera. So if EMS comes and there is they will ask, does this patient has an advanced care planning, a directive, a DNR, and they were looking the home. Sometimes we like that they place one next to their hospital bed, one in the refrigerator, and absolutely. If the document is there, they will provide oxygen. We actually in San Antonio have a mobile integrated unit that can provide morphine for the patient if they're in distress. They will be very gentle and honor it. Now, they come and they ask, and you said, I have one, I cannot find it. They're going to do all the CPR on that patient. So the documents are good to the extent that they're visible, that people are aware of them. So whatever you talk in your conversations on caregiver, if you have an extended family, when we make our copies in the clinic, we give 5 copies of the MPOA, 5 copies of the out-of-hospital DNR. We tell them to put that in the card that they use. Every child should have one, because if it's a secret, it doesn't matter. Nobody will know about it. Great question. So put yours in the refrigerator.
I have a short true story about that. A friend of mine had a heart attack at his place of employment. He was resuscitated, sent to the hospital, resuscitated in the ambulance multiple times, and his daughter came to San Antonio and said, he has a DNR. And so I went to his house to look for it just in case his heart stopped again in the hospital. I couldn't find it. They resuscitated him again, and then he went home. And he lived for another 10 years, and he thanked me. He thanked me for not being able to find his DNR. So I guess the answer is hindsight is 20/20. Speaking of paperwork, is there any paperwork that one can sign that authorizes a person to sell real estate for the deceased? Is there an affidavit of kinship, paperwork, et cetera, and what can be done to sell that property?
I think that might be a little too complicated for our panel discussion, but see me afterwards and we'll talk about it.
See Carol afterwards. Some of these are repetitive, which is why I'm moving through them. What kind of attorney handles debt collection after probate? And are you responsible for the deceased's debts?
You're not responsible for the deceased's debts, but the deceased's estate is responsible. So before the heirs get, the creditors get. So if there's a bunch of debts and there's not that much money, then the beneficiaries or the heirs get nothing because the creditors get paid. But what kind of attorney is responsible for debt collection after probate? I guess a collection lawyer.
Collection lawyer. Okay. Are you aware that even if you have signed all of the necessary papers, that you have a DNR, that if you are admitted to a hospital through the emergency room, a physician can disregard that DNR request? I have a neighbor that happened to, by the way.
The problem is, I think it's the terminology. In a fragmented system like the one that we have, where we don't share the same electronic medical record between the primary care, the ER, or the hospitals, all of these great conversations get lost. So, for example, in our system, we try to tell the patients, please go to Baptist or Methodist because the physicians can open the computer and look into the documents and more or less have an understanding of where to start. Well, that doesn't happen all the time. So there are probably cases where the physician, and that's what I will do favor in my professional and my colleagues, it's not like they disregard it, it's like they didn't know about it. And the patient shows up in the ER, the physician is not going to spend 20 minutes finding out if they have a DNR unless they brought it with the patient. Their duty is, if the patient is actively dying, they're going to, as a good Samaritan, do everything they can. Now, as soon as you find the patient has an out-of-hospital DNR, they will immediately stop doing. And that's the right thing to do, is we always favor life in the midst of doubt. Now, have somebody intentionally said, oh, I don't agree that you are a DNR, you need to change it. It maybe happened, but I don't hear that very often. What I hear is the opposite. Oh, you have a DNR, let me don't do care for you. But again, if you have a bad experience, maybe we will need to know more details. But again, that's the reason we tell families, if your loved one gets admitted, please show these documents. Because otherwise, you can get into the chance that the physician in the ER doesn't know. It has happened to my team. Patients under hospice get called 911. Patient gets intubated. To know 6 hours later the patient didn't want it to be intubated, and they are already there. It creates all sort of chaos. You know, this patient didn't make it like your friend. Right. You have a good outcome. Not many of them, but.
One last question, and then we're going to draw the final door prizes. What is the best way to approach the subject of medical power of attorney with older parents? Same question about end-of-life directive to physicians. And if you don't know who would do that, how do you find someone to go to for guidance? And that would probably be Diane, because you know who to call.
Typically, we do this a lot of in our education and training, I think, when we present. I always say sometimes it takes several conversations, right? And I have to plug, my father's here. Say that. You know, I always say we're rare in the family that my parents were like very open about the conversation of, this is what I want, this is what's going to happen, this is where I'm going to be buried, let me show you where we're going to be buried. But unfortunately, that isn't always the case, right? So it's a sensitive, nobody wants to talk about death. Nobody wants to talk about those things that may happen to us, all going to happen to all of us, right? So I kind of, again, it's just kind of broaching that subject. It could take several conversations, and sometimes too, even as a child, I say, it may not be you. You may not be that person that has to have that conversation with them. If it's a pastor or someone in their spiritual life that they not respect more, but I say I can tell my dad something, right? And doctor tells him the same thing. I'm like, Dad, didn't I just tell you that a month ago? No, but it is that idea that if there is somebody that that can have that conversation, if you as a child, or if it's again that relationship may not be open to that. But yeah, I think again it's just some of those conversations that have to happen.
You can always get a geriatric care manager to help.
Yes, and sometimes it is, again, that professional, I think in terms of, culturally, generationally, it can be someone, again, sometimes it's doctors, sometimes it's that professional that they may listen to as opposed to you as a family member. So getting those professionals involved. There's social workers, there's the geriatric life care managers, even physicians. I think that sometimes it can, listening to that person that will hopefully, they'll be open to listening and do that for
Okay,
themselves.
we're flat out of time. We're going to draw some door prizes. If you want to speak to some of the panel members, they have agreed in most cases to stay a little while. I want to thank them. Round of applause for our panel.
Thank you.
Thank you.
Thank you all very, very much.